Good afternoon. Thank you, madam, for giving me the floor. All protocols observed. Excellency is sitting on the dais, and audience, many colleagues, many friends are here. So I'm presenting this on behalf of UNFPA, my colleagues, my entire team, and I'm presenting some experience from our past interventions. And that's why I have kept the title of this presentation as UNFPA in partnership of SRHR in Bangladesh and simple approaches at scale. So being the public health agency, I think one of the focus which remains with us is on implementation and trying to see that simple interventions are taken to scale. So this is going to be the outline. Partnership is so very important. I will briefly talk about UNFPA mandate and then some simple approaches which over the past several years we have seen working and kind of playing out in Bangladesh. And then finally, I would be summing up with the main points of my presentation. So this is the first slide where we are acknowledging the partners, and we may not have succeeded in putting all the partners here. Our apologies, but without them, I think anything that I'm presenting will not at all be possible. So these are our partners. So upfront, we thank them, government, donors, partners, CSOs, NGOs, everyone. Most of the points that I'm going to present here is about Bangladesh as such, all districts. But very specifically, we have been supporting 26 districts, which had been the neglected districts. So much of the data that I would be presenting will be pertaining to those 26 districts, unless specified. Of course, some data I'm also going to show, which is about Bangladesh as such. I'm a little fast because I really want to finish all my presentations, so please bear with me. And I might not be talking too much about the numbers. You could see the numbers in the graphs. So this is UNFPA. UNFPA is the United Nations SRHR agency. And our mission is a world where every pregnancy is wanted, every childbirth is safe, every young person's potential is fulfilled. And then SRHR in its gamut includes maternal health, midwifery, MPDSR, obstetric fistula, family planning, STI, HIV, AIDS, urban health, cervical cancer, health sector response to gender-based violence. And I'm going to talk about all of those. So now the simple approaches that I have been talking about. So I start with maternal health. This is the picture of a labor room in a facility. I just forgot to mention that all pictures here has relevance. And the first picture which you all saw was from Cox's Bazar, recently taken, where the community health worker was going from house to house talking about family planning and integrated SRHR. This is simple standardized approaches that we have been talking about, and these are happening in this country. I'm very briefly talking about it, and these specific interventions have been put in place. ANC, PNC corner, facility delivery centers or spots, then oxytocin and cold chain at facilities, a specific corner for addressing PPH and pre-eclampsia, eclampsia complications, waste management, and then skin-to-skin care. So these are some basic interventions which we have taken to scale. Now, on maternal health, without safe delivery, I think the entire discussion remains sort of weak. So here specifically in the labor room, an ideal labor room should have that type of setting. It should have a birthing chair, a birthing ball, and of course, midwives. Without the health provider, I think the facility room remains kind of non-functional or weakly functional. And then specific corners for PPH and eclampsia kits, and then the use of partograph. Then what we have seen is that those are the numbers which have seen increment on ANC, on the usage of partograph, on institutional delivery, on skin-to-skin care, on increase in PPH and eclampsia management, and then decrease in the number of or percentage of cesarean sections. And of course, all the facilities which we are referring to in this presentation have 100% midwives availability, facilities having ANC and PNC corners, and then the facilities are ready. And on the other hand, you are seeing we have a World Bank supported intervention called as Health Gender Support Program in Cox's Bazar. There, by our interventions, we have put midwives in close to about 45 union level health facilities. And in last 1.5 years, we have seen the increment of institutional deliveries by about 117. So that's just one small bit. This is about midwifery. This is a picture showing where a midwife is conducting delivery in the bus while the woman was going to the health facility. So those are basically the pillars of midwifery: governance, education, advocacy, and service. I wouldn't go into the detail, but we all know that in 2010, when our Prime Minister went to the General Assembly of United Nations, she announced that this country is going to do a great work, going to recruit about 3,000 midwives. All that has happened. I will briefly, in the interest of time, would simply say that as we stand and speak today, there are close to about 8,000 midwives in this country, and this all happened between last, about 13 years. So starting from 2010, the whole wave of interventions started into midwifery, as a result of which today midwives are one of the very strong cadres of public health in the country. And all the little bit of things which are so important in taking the profession forward had been happening in last 10 years. And all those things are mentioned there. I'm not going to talk about those. Just very quickly on the governance side, I mentioned there are about 8,000 midwives in the country. There are 62 public sector midwifery schools, about 108 private sector public health schools. There are about 3,500 midwives graduating in this country every year. There are about 300 midwifery teachers in the country, and then so many other things are there. And on the practice side, I would just like to say that in the public sector, there are about 2,500 something midwives already working. We have about 95% facilities, which we are referring to in this presentation, fully equipped with midwives and all other facilities. And then this year, given the important role of midwives in trying to increase and improve institutional deliveries, government has decided and announced that 500 union level health FWCs will be equipped for 24/7 services, delivery services. And then the last point I would like to talk about on this slide is that our experience has shown that midwives, there is increase of about 57% deliveries conducted by midwives over this period of time. These are some unique examples. I don't have time to talk about them, but it is about specific midwives who are unique and who are unique. Of course, the whole cadre is unique, but these 4 women in this particular slide is about, I would say, tremendous and remarkable work that they are doing. One is about the Santhal community. We supported a few girls from that community to become midwives, and they started normal delivery in their communities for the first time in the history of Bangladesh or the independent Bangladesh. Bandarban, we all know that it's a difficult terrain, and there they go to the far-reached areas through midway homes, and they not only just provide the delivery services, but they also do outreach. There is this Dohar, who has been awarded by the minister for conducting 600 deliveries, normal deliveries, in a span of 1.5 years' time after she graduated. And then you are seeing the telemedicine service in which midwives took a very, very prominent role during the time of pandemic. And our donors, one of whom and others are also sitting here, who have very generously supported us for this exercise. And these are some numbers which I am showing. I'm not going to talk about that. The only message from this is that both nationally and in the 26 districts, the number of deliveries or the percentage of deliveries by midwives have been going up. The one in the 26 UNFPA supported district, you would see that the starting point was 17%. And these were the districts, as I mentioned earlier, are the ones which were lagging behind already at the baseline. MPDSR, this is the community autopsy which is going on. The picture is about that. I will just briefly talk about, we are here from 2010, where MPDSR was in one district, but today it is in all 64 districts. A lot of background work has been done, national guidelines have been developed, a lot of tools have been developed, and people in the know would acknowledge that by and large, every district is conducting review meetings. And I will not be able to finish my presentation, but still I would like to kind of do as much as I can. Obstetric fistula, we are a major player on obstetric fistula. This is the picture of a tea garden. There is a cluster of about 15 tea gardens where they have been declared as fistula free. And again, all the background work, enabling environment related interventions were done in order for that to happen. And we are in 4 regions. There are many hospitals, district hospitals, where you have fistula corners, and there are centers of excellence in the country which are providing trainings and conducting surgeries. So this number is simply telling us that in last 4 or 5 years, how many cases were operated and what was the success rate of that. Family planning, I will just gleam through it. I just want to talk about facilitators. This is a specific cadre that had been supporting district administration in running the family planning programs, and they have done a tremendous job. The graph on that side shows their number and the visits that they undertook. Another cadre that we would like to talk about is FP counselors. They have been playing a very important role, and I think these are silent players who are quite critical in providing these services. There was an intervention whereby for delaying the pregnancy, young people were given at the time of marriage registration some gifts, and there had been a very positive impact of that intervention. And very briefly telling that there was reduction in first year of pregnancy between the intervention districts and the control districts. This picture is about a young girl who got a married woman, relatively young, and she used PP-IUCD soon after her delivery. And there are a lot of research which is talking about the suitability of PP-IUCD or IUCD for the young people. And the message here is that this PP-IUCD intervention or PPFP intervention needs to be scaled up in all the health facilities of the country, especially DGHS facilities and DGFP facilities, including the private sector. Those are the numbers which are simply giving the numbers of the new acceptors for both the regular long-acting reversible contraceptives and also for the PPFP interventions. Cervical cancer, I will just briefly talk about that we are present in about. So the cervical cancer corners are in 24 districts. All the 24 district hospitals have the cervical cancer program running. We have Dhaka Medical College, which is the center of excellence, and those are the numbers which are showing that how many women were screened and how many were found via positive, out of which how many were colposcoped and what was the outcome of the colposcopy, and then of them, how many were given treatments and what was the cancer number and how many of them died. I will just now get to my last slide. I had other presentations about integrated sexual and reproductive health services for gender diverse populations, female sex workers, and also about the health sector response to gender-based violence. This I would just like to briefly talk about. This intervention, again under the World Bank project, has been started in Cox's Bazar, and for the first time in the country, all Uppsala health complexes are giving health sector response to gender-based violence, primarily the rape victim. And there is a whole sort of lineup of interventions, supportive systems which were developed in these facilities, which led to the availability of these services. And this can be a model that can be scaled up in all over the country. Lastly, I think I would like to just sum up saying that the partnership is so very important in taking the program forward and improving the availability and access to services for everyone. And I think the simple interventions for them to be kind of going to scale partnership is so very vital. There are some key human resource which is so important, and I think as the SIP is being developed and the new sector plan is being developed, all this is under discussion. Midwives, as I mentioned, community health workers, FP facilitators, FP counselors, SRHR district officers, and cervical cancer facilitators. I could not talk about them, but just to say that this cadre is so important in taking the programs forward. Integrated approach is one of the key aspects of SRHR, and SRHR being centered around midwives at the primary health care level is an example of integration, and the district health officers working very closely with civil surgeons, with DDFP and DPHN, etc., is also an example of how around one person the entire program is centered. And then I mentioned PPFP services have to be offered through all the facilities within the government setup and also private sector. And then operationalizing 500 union level health facilities. And then basic SRHR services in urban slum is important. And lastly, HGBV has to be scaled up. This is my last slide, thanking all of you. These are those wonderful, remarkable district SRHR officers who are supporting the civil surgeons and the district administrations in taking SRHR program forward. And they have been already included in the 4th sector plan OP, and we are hoping that this will further continue in the 5th sector plan. With that, thank you, and thank you for bearing me for another, I think, 2 or 3 minutes. Thanks a lot.